All right, thank you so much, and good morning, everyone. I'm thrilled to welcome my friend and colleague, Una Makris, to present today for our grand rounds, where she's going to share her research on non-pharmacologic interventions for pain in older adults. She is amazingly trained. She went to medical school at George Washington University and then came here at UW for internal medicine, and then off to Yale, back to the East Coast for her rheumatology fellowship. And since then has been at UT Southwestern, where she's now a staff physician at the VA North Texas Healthcare Center and is an associate professor of medicine. She's known throughout the rheumatology community as a prolific mentor as well as an expert in aging. To that end, she serves as the co-chair for the medical and surgical specialties for the American Geriatric Society. So she facilitates the integration of aging-focused care from geriatric experts into the medical and surgical spaces and has really been a thought leader in rheumatology in that space. She holds numerous grants, both for the VA and the DoD and the NIH, and has over 50 publications. Today, she's going to share her work on the Motivate study, where she implemented behavioral interventions for older adults with pain and depression. So, with that, thank you so much for coming today, and I'll let you take it away.
Thank you so much, Dr. Weisham, and it's good to be back. Thank you for waiting as we got the slides up. So again, I'll be talking about behavioral interventions for older adults with pain and depression, and I think we see a lot of these types of patients in clinic. So while I'll be talking about the research, I hope this may be useful clinically in some ways as well. I have no commercial financial relationships. I'm grateful for funding. I'm currently funded by a VA merit through HSR and NCCIH, NIH. The views expressed today do not reflect the position or policy of the US government. So to extend on Dr. Weisham's very kind introduction, again, I'm a rheumatologist with a great passion for moving the field of geriatric rheumatology forward. I am a health services researcher focused on improving outcomes that matter most for older adults with chronic musculoskeletal pain. Today, we'll talk about the epidemiology of musculoskeletal pain in older adults. We'll talk a lot about the need for behavioral interventions, and then I'll jump into how we developed and evaluated Motivate, a unique behavioral intervention I developed for this target population, and then we'll end with some barriers to behavioral change. So as musculoskeletal specialists, it is especially appropriate to focus on research that affects the aging population. The National Institute of Aging predicts that a very large increase in disability will be caused by increases in age-related disease, and arthritis and back pain are at the top of that list. This has enormous implications, as we know, for social support systems, resources, and our economy. The prevalence of chronic pain varies widely depending on the site of care. We know that up to 80% of patients over the age of 65 will report chronic pain, and that aging is a risk factor for chronic musculoskeletal pain. We also know from the literature that pain in later life is associated with numerous poor outcomes, including falls and fractures, depression, anxiety, suicidality, social isolation, sleep disturbances, mobility problems, cognitive deficits, frailty, and spousal distress. So today I'll be talking about back pain, and why is back pain so important? It's the most common chronic pain condition. It's the second most common reason for an office visit. Its lifetime prevalence exceeds 80%. And we know, we just talked about its considerable morbidity. Based on 2005 dollars, the indirect and direct costs exceeded $100 billion per year for back pain, and we can imagine what that looks like now. In the last decade, diagnostic and therapeutic procedures for back pain have skyrocketed. However, patient outcomes have not improved. We know that chronic back pain is complex. Why do nearly all older adults have degenerative disease of the lumbar spine? yet not all have chronic low back pain, and then fewer have disability due to chronic low back pain. We know that some of the discrepancy between imaging findings, symptoms, and function and variability in response to treatment has to do with biopsychosocial factors that influence the course and outcomes. If you're not already familiar with Deb Weiner's work, she's a geriatrician and rheumatologist at Pittsburgh. She published a wonderful series on deconstructing chronic low back pain in older adults and pain medicine. Please take a look at that series. So today we'll be talking about simultaneous targeting of pain and depression. Up to 50% of our patients with pain will have comorbid mental health diagnoses, and this may be even more common in the VA population. We know both are risk factors for the other's onset, resistance to treatment, higher recurrence and severity if either are untreated. And it's really this overlap population that's the most time and resource consuming. It's often refractory and most challenging, both for the patients and for us. And as I was choosing my niche towards the end of my fellowship, I was really thinking, what are the clinical scenarios that are most difficult and challenging to tackle? And so this is the niche that I chose to work on. So when we're thinking about conditions that are multifactorial, those with multiple contributors, interventions must be informed by a psychosocial model. And I put this slide up because really it's been around since the 1970s, at least, especially in the psychology literature. However, the uptake within different disciplines has been variable. So we really focus on the biological, but we rarely integrate the psychosocial into our practice. And so the way I practice in rheumatology, I very much focus on the psychosocial aspects of the disease and most importantly of the person in front of me, because I think if we don't address the psychosocial aspects, we can't fully address the other aspects of their health. I think we all understand that there's an urgent need for effective therapy for pain. Medications alone and surgery are often less appealing, particularly in older adults, where we often see multimorbidity, polypharmacy, frailty, fragmented social support systems. We know that long-term NSAIDs are often contraindicated in older adults. The Beers list, the Beers criteria, highlights some potentially inappropriate or high-risk medications for older adults, and NSAIDs are usually on that list. We also know that opioids are commonly prescribed. We're living through this opioid epidemic as the pendulum is swinging now, perhaps in the other direction. We're all very well aware of these adverse events included here. And we finally have evidence that opioids are not more effective than NSAIDs for musculoskeletal pain, including spine. However, I just mentioned that NSAIDs may not be appropriate for older adults. So where does that leave us? We can lean on guidelines. There are several guidelines, including the CDC and the American College of Physicians, all of which are moving towards non-pharmacologic behavioral interventions as first line for chronic pain conditions. And I don't know about your practice, but it's very rare in my practice that I see my colleagues providing or counseling about behavioral interventions first. I wanted to highlight that it's not just guidelines, it's also patients who are asking for something else. I remember when I was a fellow in New Haven, Connecticut, I received this small grant to do qualitative methods to interview diverse older adults to understand the impacts from a biopsychosocial standpoint of living with back pain. And so I would drive from New Haven to the Bronx every week to go to these senior centers to get a diverse population. And time again, they would say, I don't want another pill. If I go to my doctor, they'll give me more medications or send me for surgery. That's a gamble. Is there something else? So the patients are asking for something else as well. So we have existing behavioral interventions, and I want to talk briefly about that. We have cognitive behavioral therapy, especially for chronic pain. Anyone who works at the VA setting, we know there is a very large kind of outreach to enhance CBT-CP. However, when I was speaking to some of my mentors in pain and later life, we were kind of questioning, is cognitive restructuring the right solution for older adults who may have some cognitive impairment? Could there be something else, another type of behavioral intervention? We have evidence on mindfulness, meditation, Tai Chi, yoga. There's robust literature on physical activity, particularly for using VA data. However, very few interventions have focused exclusively on older adults or those with comorbid physical and mental health conditions. And so that's where my Career Development Award kind of came in. In 2016, I was invited as one of the experts on a panel focused on non-pharmacologic approaches to chronic musculoskeletal pain management. This was one of the state-of-the-art conferences, and this is the take-home slide after a very eventful weekend sitting together and discussing the evidence. We have implementation ready, meaning there is sufficient evidence for various manual therapies, movement therapies, behavioral therapies, and that different approaches have similar efficacy, yet no one approach is effective for most patients. And again, not many of these, if any of them, have been developed with and for older adults in mind. So with that, I wanted to develop an intervention for patients like Mr. L. This is a very typical patient I see in my clinic. 78-year-old gentleman with 20 plus years of episodic low back pain without radicular symptoms. Bending, lifting, all exacerbate the pain. He rates his pain as 7 out of 10. And most importantly, and this is what I tell my fellows and residents who rotate with me, it's not all about the pain intensity. It's really about how it impacts their function, their hobbies, what they enjoy doing day to day. He's unable to garden all afternoon as he used to. And he avoids church because he's worried about spasm. It's awfully embarrassing. And then he declines offers to see friends. He has poor concentration. And occasionally he feels hopeless and lonely. His grandkids are local, but they rarely visit. He seems to have tried everything: physical therapy, chiropractor, Tylenol, NSAIDs, tramadol, opioids, epidural steroid injections, and nothing has really helped him improve his function. His exam is unremarkable. Aside from a thin gentleman using a cane, he has some paraspinal muscle spasm and then bony hypertrophy of the knees and hands consistent with OA. On further assessment, including a PHQ-9, which is evaluating for depressive symptom severity, he does have moderate depressive symptoms. So this is my patient. I see a lot of these patients. A lot of this is existing behind rheumatoid arthritis, behind axial spondyloarthropathy, in the midst of gout. So a lot of our patients have this exact scenario in addition to the chief complaint they come in to rheumatology for. So I proposed a novel intervention so I also hope there are some trainees in the room. I'm not a behavioral scientist. I'm not a psychologist. I'm not a geriatrician. I have some identity crisis. I love geriatricians and I love aging. So I try to combine, and I work at the intersection of geriatrics and rheumatology, but I always build on prior work. So there's a strong foundation, you give them credit, and then you build and adapt for the population of interest. So Motivate, which we developed, stands for Moving to Improve Pain and Depression in Older Adults, and it has a very strong foundation on other interventions, and we'll talk briefly about that. So, oh,
That was me. I'm sorry.
oh, that's okay. Are you still hearing me okay?
Yes, I had to switch to a phone. I'm so sorry. I'm sorry, Una. I didn't mean to do that.
No problem. No problem at all. So the focus of Motivate was to develop, adapt, and to evaluate a telephone-delivered behavioral intervention for older adults with comorbid pain and depression. And this is built on that foundation of HOPE, which stands for Healthy Outcomes Through Patient Empowerment. And that was a collaborative goal setting intervention focused on diabetes and depression. And here we focus on pain and depression. So I think it's always useful when you're thinking about starting a research career, especially in an area where it's truly interdisciplinary. Think about what has worked in other fields and try to adapt that potentially for your own. The core components of Motivate include behavioral activation rather than the cognitive restructuring of CBT. So behavioral activation, and one of my colleagues at the VA and mentors, Dr. LaDonna Saxon, we were having an informal conversation and she was telling me more about motivational interviewing. And she was telling me how it's easily accessible and you don't need a PhD to learn it, and how it truly makes us stronger clinicians and helps us connect with our patients. Well, why don't I develop this Motivate using MI rather than CBT? So we do use principles of MI. The underlying premise here is that goals consistent with values will cross-cut both the physical and psychological diagnoses. And we're really focused here on how older adults are uniquely motivated to make and sustain behavioral change. Because you have the amazing Dr. Weisham and Dr. Singh, who are also very passionate about aging and rheumatology. I'm sure you've heard about the geriatric 5Ms, and we'll talk about that in the next slide, but Motivate really aligns beautifully with all of the 5Ms, what matters most: mobility, mind, multimorbidity, and measuring medications. So the geriatric 5Ms was developed by the Institute of Healthcare Improvement, and it's all about improving the quality of care delivered to older adults, keeping these very core aging principles in mind. And it started with mind, focus on dementia, delirium, depression. Here we target depression. Mobility. At the core, Motivate is a physical activity-based intervention. Medications. And then certainly what matters most. Motivate is all about eliciting what matters most in your values. And then multi-complexity was added as the fifth M by the American Geriatric Society. So a little more about motivation and physical activity. Motivation is the driving forces responsible for initiation, persistence, direction, and vigor of goal-directed behavior. These investigators looked at 89 studies to assess changes in motivational constructs for physical activity, including intention, stages of change, and autonomous motivation. And they found that behavioral change techniques that were most beneficial included behavioral goal setting, self-monitoring of the behavior, in this case it's physical activity, and behavioral practice and rehearsal. And that increases in intention and stage of change were significantly related to increase in physical activity. So this is really at the core of some of the principles of Motivate. Let me take a brief detour. It's hard to tell online who's familiar with motivational interviewing. I find this a very powerful tool, and actually I've kind of I encourage anyone who's interested to learn more about MI in your own practice. So what is MI? This is a collaborative, person-centered form of guiding to elicit and strengthen motivation to change. It's a method used for a particular purpose to help people resolve ambivalence and move toward change. You can imagine any number of such behavioral changes in your clinical practice, but also at home. I start using this with my husband sometimes. This originated with substance use disorder treatments. It's been used in over 200 RCTs. The trials encompass a wide variety of target behaviors, and it's really considered an evidence-based treatment, although it's not recommended as a manualized treatment. And so we are not a pure MI-based intervention. We use principles of MI. This is a schematic that shows how our coach, our hired and trained health coach, elicit values from our patients, what matters most to them, and then links a physical activity-based goal to their value in the hope that we activate them and motivate them to make and hopefully sustain a behavioral change. So this is a very individualized approach to changing behavior. I can't skip over the conceptual model because I work with a lot of behavioral scientists. And so this is a model pathway by which our behavioral intervention is hypothesized to improve both the behavioral outcomes here on the right side and then ultimately the clinical outcomes. So by targeting these components in the red box in the middle, we hope to improve engagement in physical activity, thereby improving both the pain and depression. I'm going to break up how we developed Motivate into various phases. In phase one, we developed the intervention all delivered over the telephone that targets older veterans with back pain and depressive symptoms. Again, we hired a health coach, and this health coach doesn't have to be necessarily someone already in mental health. We wanted intentionally to hire people with varying prerequisites so that we can show their scalability. As I mentioned, Motivate is all completely delivered over the telephone. Let's see, I wrote this in 2016, and I didn't know that there would be this COVID pandemic. And at the end of the day, it turned out to be very beneficial to have this telephone remotely delivered intervention for various reasons, and we'll talk about that later. Motivate is 8 sessions over about 12 weeks. It's particularly appealing, especially to improve access for those who are mobility limited. I don't need them to come to the hospital to conduct this intervention. We know that the types of client selected goals most often met with telephone health coaching include physical activity, emotional health, and pain management. And so that's really all of Motivate. So Mr. L, going back to Mr. L, why is a telephone coaching intervention ideal? I'm in Dallas, Texas, and Mr. L lives on the border with Oklahoma, which is about 3 hours away. And so a lot of my patients who come in with rheumatoid arthritis, with any of our autoimmune inflammatory diseases, will drive 3-4 hours to see us. But for an intervention like this, we absolutely do not want them to be driving so long. We can tackle this over the phone, and we want them to be comfortable in their own communities. Further, in rural areas, there are rarely behavioral services that Mr. L can access. So I have another project, health services project, about enhancing care for rural veterans. So we look forward to working with all of our patients in their own homes, and we're moving towards video to home technology. This is a table outlining the session content of Motivate. So the first session is really the introduction and rapport building and setting down expectations for the coach and the patient. In the second session, we used to call this values elicitation, but we learned from the veterans they didn't really know what that meant, so we changed the title to What is Most Important to You. This is really clarifying what matters most to them. And then sessions 3, 5, and 6, they get to develop a SMART goal, a physical activity-based goal linked to a value, so it means something to them, and hopefully because of that, they're more willing to engage. Session 4, I initially thought would be optional. This is challenging maladaptive thoughts. However, as it turns out, every single patient with pain and depression really needs to tackle and recognize and redirect with some of these maladaptive coping mechanisms that they've developed over time. And then session 7 and 8 is really winding down, learning how to continue the program, preventing flares, and thinking about how to sustain this once we are no longer calling them. The way we developed Motivate is really with stakeholder feedback to inform content and delivery at every step of the way. So we identified groups of experts, physicians, interdisciplinary groups of healthcare professionals, patients, those with pain and depression who are older, and then other stakeholders, including the coaches, including clinic directors, including people at higher levels who might help us scale this up if it's effective. We conducted semi-structured interviews focused on an implementation framework called iParish. This is a VA-developed implementation framework. It stands for Promoting Action on Research in Health Services. And this is a really nice framework to develop the discussion guides as we meet with each of the groups of experts, veterans, and stakeholders. And we really tailored our discussion to the stakeholder group. So for example, for veterans, we wanted to make sure that the messaging and the wording of the content was understandable. For other stakeholders, I really wanted to ask primary care doctors, how do you want the the information communicated back to you? How can we be least disruptive because you are so busy? So we wanted to develop this truly with an eye for implementation and scalability. In phase 2, this is essentially a single-arm rollout of the intervention in very few veterans. In order to refine the content and delivery, here we identified the coaches, we trained the coaches, and then we rolled it through 10 veterans. The inclusion criteria are both men and women over the age of 65 with low back pain on most days for the last 3 months that interferes with daily activities. We wanted them to have a depressive symptom PHQ-9 cutoff score of 10 or greater. That signifies moderate depressive symptoms, and usually those are scores in which we would make an adjustment in management. They need to be capable of participating in a home-based physical activity program without current concerns about active chest pain, shortness of breath, balance, or falls. I'm very concerned about falling in the community, so I train my team heavily in that area. They need to have a telephone. They are excluded if they have uncorrected hearing or visual disturbance. Uncorrected visual disturbance is a risk factor for falls. And then hearing, they need to hear us over the phone. We also, I didn't talk about this, but we send them a pedometer. I needed them to read the screen to report back on step counts. If they had moderate to severe cognitive impairment, they were also excluded. And then they had to be able to ambulate. We never use the word exercise, and that's actually another kind of tip. We don't frame this as an exercise intervention. That one word tends to put off our older adults. They think that exercise is not necessarily for them. So we call it physical activity or a modest walking program. And then we found, if they've had acute illness requiring hospitalization in the last month or so, they were more likely to have a recurrent hospitalization. And then we spend a lot of time talking about suicidal intent and safety from a psychological standpoint. The outcomes for this stage of the study included mostly feasibility. Can we recruit? Can we deliver the intervention with fidelity? How many sessions per subject occurred? What was the average time per session? What are the potential harms and risks? Could they use the pedometer? We found that a lot of the patients were losing the pedometers. How are we communicating instructions for how to utilize the program? Can we capture steps per week? The primary outcomes of interest for us as rheumatologists and clinical investigators included pain interference using the PEG-3, a physical function self-reported disability instrument called the Roland-Morris, and then depressive symptoms with the PHQ-9. Again, this was the pilot phase, so we were focused most on feasibility outcomes, but here we're looking at trends and preliminary outcomes. These are secondary outcomes, and I just want to highlight how important it is to be cautious of how many secondary outcomes you include in your study, because you can really have survey fatigue and you don't want your patients to drop out of your study because it's just too burdensome. But I think it's important to capture other aspects of the pain experience. So we capture social functioning using very brief PROMIS, the patient-reported outcome measurement information system. The PROMIS toolkit has incredible instruments that you can use. We do measure therapeutic alliance and psychological resilience, and then some healthcare utilization outcomes here. This is a figure showing the timing of assessments and intervention sessions. Here you see on the top how health coaches deliver sessions 1 through 8 over the telephone. They have 1 week in between unless they are practicing a goal, which is the sessions in red. They have 2 weeks to practice that goal. And then we have a whole team of blinded kind of research staff who obtain outcomes assessments at baseline, mid, end, and then for sustainability, we look forward to 6 months. Phase 3 is to conduct a pilot RCT to assess feasibility for older veterans with pain and depression to either assigned to motivate or the comparator. And in this case, we decided to use a waitlist control. And I went back and forth and I met with multiple colleagues around the country as I was writing this grant and revising the grant over time, and decided that the waitlist control felt the best to me because ultimately once they complete their usual care and their assessments, everyone would be offered Motivate. And again, our goal was feasibility and evaluating just the trends in outcomes. This is an overview of how we are recruiting patients. We do the baseline and then randomize to either the comparator or telephone intervention, and then we have a mid-intervention and then a post-intervention assessment, and then follow-up to evaluate for sustainability. So these are our preliminary results. We enrolled 50 subjects. The recruitment rate was about 11%, depending on where we cut that off, about 18%, 11 to 18%, which is very typical of pain trials. And then when you add on older adults and depression, I think this is pretty typical. We have a very, I would say, effective and streamlined approach of recruiting using an IRB opt-in, opt-out letter approach. And so that really expanded the pool of patients. I'm happy to talk about that if anyone's interested. And the reasons, we learned that the reasons people were screening out, number one, they're not interested in research, and I think we see that often. Many of them were not depressed enough. They didn't reach our threshold, so we're very happy about that. And then some, were too active. We had a threshold of activity in the beginning, which then we dropped, but many of them were already quite active. This is the consort diagram. I won't go through this, but let's just say we learned a lot about gathering very granular data on screen failures and why and when patients dropped out. So for me, as someone who is just beginning in primary data collection and trials, all of these initial steps and processes were critical to train myself and the team on how to gather all the data we need. These are some baseline characteristics overall by the control group, which was waitlist, and then Motivate, and we see the average age was about 70 years old. We had 20% women, which is quite good for VA. We had a diverse sample with 46%, or let's say 50% white, about 40% African American. Our patients live about 30 miles away from the local VA, community-based outpatient clinic. And then here you see that the baseline PHQ-9 score on average was about 13, PEG-3 was about 6, and the Rowland-Morris was about 17. At baseline, the average step count just for the Motivate arm was about 2,400. So we found that Motivate was feasible. They could use the pedometer, they can connect with the coaches. They engaged very well with the coaches. The coaches were able to deliver Motivate with fidelity. I created a checklist. I check all the fidelity. And really, they were able to use MI skills where they cultivate change talk, softening, sustain talk. They show partnership and empathy. and I would give feedback to the coaches to prevent drift. We found that the step counts improved to 4,300 by mid-intervention. And we found that veterans would complete our tracker. They had some homework in between sessions. However, this was very cumbersome, and I was the one reviewing it, so I had some ideas on how to make that more efficient. So again, these are preliminary results, just trends. It's a pilot study, so we're really not powered to talk about p-values. Here in the top left side, we see the PEG-3, which is our pain interference outcome. In blue, we have motivate. In orange, we have the control arm, and at baseline, the PEG-3 score starts at about 6.7, and we see here by the end intervention, it drops to 5.13. A 1-point difference is considered clinically significant, and you see there's at least a 1-point difference between the control group and the motivate group at the end of the study. Similarly, we see promising results for the PHQ-9. Again, the blue is that motivate arm, and because our sample size was rather small, we don't start exactly at the same place, so we hope that will change once we have a larger sample size. But again, we see that our patients start with a PHQ-9 of about 12.7 and drop to 7.4. So a clinically meaningful change for the PHQ-9 is a drop of about 5 points or a drop under 10, and we see that's the case here for PHQ-9. Again, similar trends in the right direction, in a promising direction for the disability Roland-Morris, for physical function. We see that self-efficacy here in the blue group improves compared to the control group. Our resilience scores have some improvement as well. So in general, we have some trends in the right direction. So based on that, I submitted a merit review, which is an R01 equivalent through HSR, and I'm very grateful that we have next steps to report on. We're currently in the middle of this AIM-1. It's a hybrid type 1 effectiveness implementation randomized controlled trial where we're taking this to the next level. We are in the middle of recruiting 264 patients from 2 large VAs in Dallas and Houston and the surrounding community-based clinics. We dropped eligibility to age 60. We expanded from back pain to all musculoskeletal pain, and again with comorbid depressive symptoms. And my question really was, can we capture steps, pain, and mood using technology? So we've incorporated some of that. AIM-2 is to evaluate what worked and didn't work. The implementation processes, again, using iParish. This is the qualitative aim. AIM-3 is a budget impact analyses. So if AIM-1 is effective and we show the effectiveness of Motivate, we want to be able to have a business model and take this to central office and talk about how can we scale this up to all VAs if it's effective, so as many older adults with pain and depression can access this. I'm not going to go through this, but this is our table from the grant, basically talking about what is the source of the data. And so we just learned a tremendous amount from the early phases that I presented. This is an example of our intervention manual. The VA has very strong medical media, and so I provided a very, I would say, modest Word document, and they created this beautiful product. This is just an example of where we emphasize social support and sustainability. Really try to find someone in your community that you can work with who can almost replace your health coach once the program is over. As I mentioned, I spent a lot of time talking about fall prevention, but also suicide assessment. So my team, both in Dallas and Houston, is very familiar with the Columbia Suicide Screener And we have our local Motivate processes that completely align with the national suicide assessment protocols. So I just want to end really with this slide that talks about continuous veteran and stakeholder engagement. And I think this is one of the aspects of working at the VA, but also doing research and, having a career in aging at the VA that is absolutely gratifying, and that is involving veterans at every step of the way. I can safely say that we developed this intervention with and for older adults, where we, from AIM 1 here all the way to AIM 3, and even now, we're iteratively refining our processes based on feedback from various stakeholders. If you're familiar with the whole health initiatives at the VA, it's very, I would say, timely for our team that Motivate is being evaluated at a time where whole health is taking off. And so there are quite a few whole health coaches out there. And my dream, if this were to be effective, is to train whole health coaches who already receive MI training in this intervention specifically. And that would be a very nice mechanism and way to scale up nationally. So with that, I want to move to speak about some known barriers to uptake of behavioral interventions. And I think this is really important to speak with, my colleagues in rheumatology here. Both patients and healthcare professionals tend to have a pain mindset that may include a quick fix or passive strategies. We may focus on pain relief over function because honestly, focusing on function may take longer than focusing on pain relief. So I want us to all think about our own pain mindset. And unfortunately, behavioral treatments are still viewed as an afterthought, sometimes less effective, a last resort, or stigmatized. So what I like to do is I like to bring this up at the initial visit, along with other pharmacologic modalities, so that they go hand in hand. When I'm speaking about barriers to uptake, I also want to highlight ageism, because I work in this kind of geriatric rheumatology world. I'm moving in this area because I'm trying to understand what ageism looks like in rheumatology, and it's really everywhere. And I think it's important for us to be aware of why we may not present options to our older adult patients. So the WHO defines ageism as biases we have as to how we think, feel, and act towards others or ourselves based on age. Discrimination or implicit bias based on age is pervasive in society and strongly influences treatment of chronic conditions and perceptions. So I think this is very common as we think about proposing and communicating behavioral interventions, but I also want us to think about when we talk about initiating biologics in our older adult patients. I think this comes to play. Ageism intersects and exacerbates other isms. Ageism is a social determinant of health that has come to age. I like that quote. A little more about ageism. There's two distinct targets: other directed, when we think older adults are slow or wise, and self-directed. I have negative feelings about my own aging. I see a lot of self-directed ageism in my clinic, particularly. There are 4 types: personal, institutional, for example, when we see older adults excluded from randomized controlled trials; intentional; unintentional. This was a nice article published at JAMA Network, evaluating the prevalence of everyday ageism. So these are stereotyping that older adults encounter in their day-to-day. They evaluated over 2,000 adults, and they found that over 90% reported one or more form of everyday ageism. Over 80% reported internalized ageism, and this category was associated with the greatest risk of poor outcomes for all health measures. and then 44% reported interpersonal ageism. And I just want to focus very briefly on this 80% internalized ageism. I tend to see a lot of older adults in my clinic, and whenever I bring up the topic of initiating Humira, let's say in a patient with RA, they will often tell me, no, this is for younger people. I don't need this. I've been dealing with this all my life. So we have very nuanced conversations about how to tackle their internalized ageism. And ultimately, the decision is theirs. But it's important for us to recognize how common internalized ageism is. So I'd like to, leave on a positive note that ageism can be combated either with policy, we can protect human rights and address age discrimination and inequality. Intergenerational interventions are fantastic. And then I think a lot of the most effective ways to combat ageism are educational activities, and I hope to see more of that in our field in rheumatology. So what are the clinical implications and future directions of what I discussed today? Again, my overarching goal is to develop high quality, effective interventions that can be feasibly integrated into care for older adults without placing additional burden on healthcare providers. I look at something like Motivate, this behavioral intervention, as an extension of what we do in clinic. How can we improve access to adjunctive behavioral options that are developed for and with older adults? I feel that health coaching can augment the care that we see in primary and specialty and mental health care. How can we incorporate technology to capture dynamic variables and assist with sustainability? And how can we use social environments, including caregivers, family, friends, to help sustain behaviors? And when I say sustain behaviors, I'm also thinking about things like medication adherence. Yeah. So take-home messages. It's important to consider multiple modalities to manage pain in older adults. This is a condition with multiple contributors that will ultimately need a biopsychosocial approach. Health coaches that are trained in motivational interviewing can help change behaviors. Physical activity can help both pain and mood, among other important outcomes. And this is something that I urge our fellows and residents in clinic to focus on quite a bit. How do you go about counseling about physical activity? It's an awareness of barriers to behavioral change. Here we talked about physical activity are so important. So safety, health, motivation, confidence. And I want to leave with this statement, each of us plays a role in acknowledging and combating ageism. So pay attention to the ageism around you, both internal and external. And how can we role model behaviors that combat ageism? I want to acknowledge all of my colleagues around the country, really, that started with the Career Development Award, and many of them are now collaborators on the Merit. I have a very wonderful, diverse team here in Dallas and the Houston VA. I started working recently with the Puget Sound VA and Dr. Steve Zelliat on AIM-3 with the budget impact analysis. So it's really fun working with his team. And I want to thank my VA partners. The beauty of VA research is really they invest in you as an investigator, but also in an idea that they feel can be scaled up and can improve outcomes in the care for many, many veterans across the nation. So with that, I will end, and I thank you for your time. I'm happy to take any questions.
Thank you so much. Danielle, my video is blocked probably because I shifted to a new technology. Apologies, Una, for that sound bite in the middle. What a wonderful talk. Thank you so much for sharing your work and kind of the journey you took to get where you were. I'm letting people take some time to put some questions in the Q&A. I'm monitoring that, but I have a couple things that I'd love to ask you in kind of the remaining 5 minutes. So if others have questions, please, feel free to put them in there. I don't want to take over the question and answer session, but I wonder, as you've gotten some feedback from your pilot, what were some of the take homes, the like kind of things that really sat well with the veterans? And then on contrast, what were things that your intervention, I know the questionnaires were burdensome, but like maybe part of the kind of like getting into the motivate and kind of making people dig deep. What were did you have any negative feedback about kind of the coaching and making people do a little introspection?
Yes. So on the positive side, they loved the remote delivery. They loved being at home. They loved the social connection with the health coach. And I think I briefly mentioned it during the COVID pandemic and during quarantine, particularly, we saw so much social isolation, and we see the residual from the quarantine still. And so these patients love the check-ins. They love that someone is calling them and focusing on the pain and depression. For a subset of these patients, one of the downsides is some of them do not recognize the connection between pain and mood and physical activity. And some of them, not all, but there's a distinct group that get a little angry, actually. And some of them have dropped out because of this, because they don't recognize how their depressive symptoms interact with the pain.
Yeah.
And so part of our session one is didactic and educational, trying to really educate patients about that connection. Some of them don't want to have that.
Yeah, amazing. Have you considered, because veterans are very social, and we're all social creatures, but veterans are particularly social within kind of like veteran groups, right? So some of them are kind of cast outs of society because of their experiences, whatever, but they love to come to the VA and chat. Have you thought about harnessing peer support and peer coaches?
I think it's a brilliant idea, and I tried to reach out to the mental health peer support specialists to train them, and they just didn't have the bandwidth. But that was actually a target for my interventionalist. I ended up hiring my team, but the goal is to train whole health coaches, but then these peer coaches as well, just to try to show that this is an intervention that can be taught to almost anyone. And the key is that the person, the coach delivering it, just has to have that desire to connect with patients and get to know them and
Yeah.
coach them to effectiveness. Yeah.
We have a question in the chat. I'm going to go ahead and read it. So this is from Mark Winter. He says, very exciting and important, with an important impact. You mentioned investigating the use of technology. What technologies do you plan to investigate? Are there useful apps available you could think that could be used? Or are you thinking about developing apps, especially that might be used for longer term follow-up?
Thank you, Mark. I think I have a one-on-one with you later. I can't wait to chat more about this. What we're using is a VA-based technology. It's a texting system that has been developed for clinical practice. It's called Annie. And so we worked with the national development team to create our Motivate protocol. And so we text, so veterans can opt in to use Annie, and many of them love it. They're texting their step counts. I've programmed it so that I don't bother them. It's not too much of a nuisance, but they text their step counts, their mood, and their pain score. And so that's very useful use of technology. And I think actually it may help with sustainability. It's a constant reminder of, are you working on what, we set out to do? Are you working towards your goal? That's one of our questions.
That's awesome. All right, Una, I want to make sure that we stay within the hour. Thank you so much for just sharing the journey. It's so impressive to think about how many people you worked with to inform this project. It's, amazing and also a little bit overwhelming as I think about kind of the next step in my world. Um,
I'm
I,
so grateful for all the people I work with, and for you, Dr. Weisham and Dr. Singh, and thank you for having me.
yeah, thank you so much. Enjoy the rest of the morning and thank you for sharing.
Thanks. Bye-bye.